Government involvement in things like neuropsychiatric symptom, both recognition and management, is probably a mixed picture. There are new ICD-10 codes as of last year that expect a clinician to not only identify that this is a major neurocognitive disorder, which is our technical term for dementia, but also the stage of illness, and not just with or without behavioral disturbance. And behavior, of course, is a misnomer for neuropsychiatric symptoms, but which neuropsychiatric symptoms have been expressed. So that could be potentially very helpful if it guides clinicians toward being more specific in their diagnosis, which would require them to be more specific in their assessment. They would have to ask the questions. That could be helpful. It could be helpful in health services research if we can look at a large scale to see how many people in moderate stage Alzheimer's disease, for example, are experiencing anxiety or psychosis. The challenge is what we have today for that assessment or for that diagnostic code is very generic most of the time. So it could potentially be helpful to be more specific in your diagnosis. The uptake will be the answer to see if that really is meaningful. Policy makes impacts in other ways in the treatment of neuropsychiatric symptoms, of course. So as part of our safety regulations, we consider things like high-risk drugs, and the highest risk drugs have something called a black box warning on the information about the drug. There are black box warning drugs in every specialty, not just in neurology or geriatrics or psychiatry, but in our space, in dementia care, in certain environments, in particular skilled nursing or residential care facilities, the awareness of using a medication that has that black box warning can also be construed as a warning against its use, when in fact that may be the most appropriate treatment. Something like a black box warning is intended to guide a clinician to consider, this is a high-risk medication. Do the benefits outweigh the risk? Is there a way to minimize the risk or mitigate that risk? Those are the considerations as a clinician. They should not be an absolute exclusion to use something that could be effective for this person, and by treating that neuropsychiatric symptom, improves their quality of life and reduces their caregiver's distress.